Thanks Kevin, thanks Janice, and thanks everyone for inviting me here to speak to you about this disease, fibromuscular dysplasia. So I'll launch right into it. I'm an interventional cardiologist, and I also run a basic science lab, and this is 2012, it's June of 2012, and I'm on call for the catheterization lab, dealing with people with heart attacks at 2 in the morning. We got a call from the emergency room that a 37-year-old girl who'd given birth 1 week previously had come in with a large heart attack on EKG. So it's 2 in the morning, we took her to the catheterization lab, and what you can see here, this is my catheter coming up here, catheter engaging the left main coronary artery. This is the left anterior descending coronary artery, which is the most important artery of the heart, and it's basically spontaneously torn itself to pieces. This is called a spontaneous coronary artery dissection, which is a rare disease, but it is associated with childbirth in that, as you know, when childbirth occurs, there's a bunch of hormones that circulate, estrogens and so on, that soften up the birth canal to allow the baby to pass. Those same hormones unfortunately soften up the arteries of the heart. And once or twice a year we get these women coming in with this situation, and most tragically, once every couple of years they don't survive with a newborn baby. So I'd been sort of mulling this disease over in my head. We put this wire down, and this is a pullback picture through the artery. We're coming from distal to proximal. What you can see here is this tissue flap, 2 lumens. This is the true lumen, this is the false lumen with blood passing down it. You can see the artery is basically just shredded. And coming back, this is all hematoma now around the vessel. But I, for technical reasons, had to do this to figure out if we're in the right place. Was able to successfully put a stent and fix the situation. She obviously survived with mild to moderate left ventricular dysfunction, but we at that time were appreciating this disease, spontaneous coronary dissection, was one of the phenotypes, one of the manifestations of this other disease, fibromuscular dysplasia. So on the way out of her heart, I shot these pictures of her kidney artery, and this is her right kidney artery, right renal artery. And what you can see here is this beaded appearance, and this is what's classic of this disease, a string of beads appearance. So she actually had this disease, fibromuscular dysplasia. This is it here. You can see the renal artery, the carotid artery. This disease affects any medium to large size artery throughout the body. And I'd been thinking about this disease for a number of years. It was at the time probably the most devastating disease that we saw from time to time, about which nothing whatsoever was known, nothing at all. It was first recognised in 1938, and it was this case that really gave me the kick in the rear to get moving and start to try and work on this disease and see if we could figure out what actually causes it, and eventually hopefully work towards a cure. So what was known about this disease? This is all that was known. From some histopathological studies in the 70s, it was known that there was a bunch of sort of fibroblast cells, which is a specific type of cell that overgrow in the vessel walls, that there was all this matrix and collagen, this sort of protein deposition in the wall of the vessels. Someone had done some electron microscopy studies from 1975. This is when these patients were previously operated on. They're less operated on now, and they're dealt by people like me in the cath lab with wires and stents. But it was shown from back then that these fibroblast cells basically had abnormalities in the cell architecture and cell structure. And that was the total extent of the knowledge about this disease. This disease, fibromuscular dysplasia, could occur spontaneously and sporadically, but there were certain family pedigrees that we had here. This is a true pedigree. Parents were deceased. Mother died in her 60s, but she had hypertension, and hypertension is the manifestation from renal artery involvement, where you get narrowing of the renal artery that causes elevated blood pressure. 2 sisters were affected. 1 sister was not affected. A bunch of children. The median age of onset of the disease is in the sort of 40s to 50s, so it was too early to know if these kids had the disease. They'd been screened but were found to be normal, but we weren't sure if they were just too young to manifest it. Really, basically what I'm trying to tell you is this very, very lousy and limited family pedigrees from the purposes of classical genetic studies and DNA-based approaches. So these are the only 3 people we were sure about, really difficult, challenging pedigrees to work on. So nothing whatsoever known about the cause other than those studies. However, at Mount Sinai was this guy, Jeffrey Olin. Some of you will have heard him, all the faculty will know his name. And Jeffrey Olin happens to be a world leader in fibromuscular dysplasia. He had a clinic of hundreds of these women, only one of a few specialty clinics in the country that dealt with this disease. So I partnered with Jeff, and we set about designing a study we called the Define FMD study, obviously trying to define the basis of the disease. And DNA-based approaches had failed. We decided to focus on the cell and to study fibroblast cells, as I said, because we knew that these fibroblast cells were likely involved somehow in this disease. At that time, 2012, induced pluripotent stem cells were being taken by a skin biopsy, and we knew that if you take a small piece of skin, you can get this sort of 2 to 3 millimetre piece of skin, you can plate it out in a culture dish, and over about 6 to 8 weeks you can get sheets of these fibroblast cells growing from a skin biopsy. So here you see a few thousand fibroblasts on a culture dish. This is a piece of skin here, and these cells just grow out from the skin over about 6 weeks. You can then harvest these cells, you can look at their phenotype, migration, proliferation, or you can do RNA sequencing and look at the genetic profile of these cells. So we built this study design. We're not focusing on DNA, but focusing on cells, looking at the fibroblasts and their gene expression pattern, fibroblasts and the phenotype, so proliferation, migration. We also, of course, collected blood, plasma serum, and we eventually came around to looking at protein levels in the blood. And we did collect DNA as well, so we could marry that all together, and brought this all together with a systems genetics approach, leveraging on the expertise of the genetics department and Eric Schadt and all the people that he brought, which are true experts in systems biology. So definitely a team effort. This was Valentina from my lab. We've now enrolled 355 people into the study. About half are cases and half are carefully matched controls, and we're still recruiting 2 to 3 people a week. So what have we done and what have we found? We've done now a lot of analyses on these cells, on the samples from these patients. I don't think I'll ever be as pleased as the day we found in an international collaboration, we pooled data and managed to find the first gene associated with this disease called PRACTA1. And whilst that identification of that first disease didn't really shed a lot of light on the biology itself, it told us a lot about the architecture of the disease and what type of genetic basis it has. So it turns out that this disease is this gene is a gene that's involved in multiple other diseases, including migraine, headache, coronary artery disease, and others. That really puts this fibromuscular dysplasia not actually in the basket of a rare disease, but in the basket of a common disease, but just a common disease with actually having very rare manifestations. And subsequently, people have looked at renal arteries from kidney transplant donors and found that maybe 1% or so of kidney transplant donors, the arteries of those healthy donors, actually have this disease. So it turns out to be a very common disease, but actually with extremely rare manifestations. So we've subsequently gone on to find all of these other things about the disease. We've actually found that spontaneous coronary artery dissection is associated with that same gene. We've actually analysed the blood parameters and found that there's actually a protein signature in the blood that's enabled us to work now towards a test for this disease, which we're about to publish soon. It's been a huge team effort, and these are the people I've had the privilege to work with, but one of the most satisfying things has been connecting with the patients. This is Pam Mace, who's the director and founder of Fibromuscular Disease Society of America. She suffered from 3 strokes and a heart attack as a result of FMD. We work very closely with her. She's a subject in the study. She's actually visiting us next week to see what is this. This is the mouse aorta. We've now actually generated the first mouse model of this disease, and she's spending the day with us just to actually look at the mice because she's so excited about the progress we've made. So that's our approach to this so-called rare disease. I'm pleased that we've actually figured out the genetic basis of it and we're pushing forward. But I think as this embodies this hackathon, it was really a combination of some interesting ideas, a novel approach, building a team, and sticking at it, some perseverance and resilience to finally come through with what we believe is some pretty exciting data. Thank you and good luck for the weekend. Are there any questions from me? Oh, yeah, up the back.
Have your findings led to any changes in management or intervention?
No changes yet, but we've actually developed a test, as I said. It's unpublished. But that test, we believe, will change management because the only way you can diagnose the disease now is by tests involving significant radiation. So you saw me doing angiography on a young woman. The other way is by CT angiography. So we believe the test will enable you to at least screen and follow these patients without exposing them to radiation. So that will be something, we'll obviously have to validate this test and go forward, but over the next 5 or so years, we hope we can reduce the burden of radiation on these young patients. Thank you.